Hello, and welcome to the first recording about neonatal resuscitation. The big focus of this one is going to be the transition physiology between intrauterine circulation and extrauterine circulation, and then a little bit about the teamwork that goes into the whole transition period. How many people do you need? What all is entailed there? So let's get started. Key points that we're going to be focusing on is that most newborns do make the transition to extrauterine life without intervention. The most that neonates traditionally need is just a warm, dry stimulation just to get all that fluid and stuff off of them so that way their exposure is limited. And if everything's going okay, hopefully that we could get them back skin to skin with mom as soon as possible, not even take them to the warmer in most cases. So most newborns do make that transition to extrauterine life without intervention. It's very difficult for us if you're used to going to high-risk deliveries or you are about to go to high-risk deliveries. You're going to see a lot of the time that they may not do that because your exposures to the extreme cases. However, just give you perspective, right? Most babies will make this transition without any need for CPAP or positive pressure ventilation or suctioning or anything like that. So just keep that in mind. Before birth, pulmonary blood vessels in the fetal lungs are very tightly constricted, and we're going to go deep into that bullet point there. And then as in the alveoli inside are filled with fluid and not air. And you want this because that helps expand and give pressure to expand the tissue to develop the lung tissue in utero. So if we want good lung tissue development in utero, we want good amount of fetal lung fluid, right? And so the big difference here now is when this kid comes out, we need to get rid of that fluid so that way they can breathe air. And so that's a definite point of transition to make sure that the baby's managing that fluid as well. Newborn resuscitation is usually needed because of respiratory failure. On your adult patients, traditionally it's cardiac failure that leads them to need resuscitation. However, when this happens with neonates and even some pediatric patients, when this happens, it's usually because of respiratory failure. So one of the most effective things for neonatal resuscitation is going to be effective ventilation of the lungs. Traditionally, once you see effective ventilation of the lungs, you're going to see their heart rate improve. And in fact, that's the number one sign that you are effectively ventilating a child is their heart rate starts improving. So that's something that you need to pay attention to as you're doing this. Do I see good chest rise? Do I see their heart rates improving with this? If you don't, then you need to take corrective steps, which we'll talk about Mr. SOPA and all that. The most important step in neonatal resuscitation is to ventilate the lungs. So even before we do compressions, you're going to be giving them ventilations. So that's positive pressure ventilation. So if a kid comes out, they're floppy, they're apneic, their heart rate is, let's just even say undetectable, we're going to start positive pressure ventilation. That is what they traditionally will respond to. So it's truly airway, breathing, circulation. So the most important effective step in neonatal resuscitation is effective ventilation, right? So that's going to be a big focus of this. And your skill development, whether it's with a T-piece resuscitator or with a flow inflation bag and mask, is going to be a key component into effective ventilation. Now, most adults, like I was saying before, it's cardiac failure, and compressions is a key component to getting them resuscitated. However, in this situation, it's going to be ventilation. Very few newborns will require chest compressions or medication. So that's a good sign. That's a good thing. And it just reiterates the point that effective ventilation is a key skill, a key focus during resuscitation or during transition if they need extra support during transition. As long as that baby's crying and screaming and pinking up and looking and have active motion, right, which we'll talk about the APGAR scoring in a little while, that's going to be a big sign that they're effectively ventilating, right? So compressions and or medications are fairly few and far in between when it comes down to it. In my 10 years of experience, I had done compressions maybe a couple, maybe a little bit over 6 or 7 times or so, but most of the time the focus is effective ventilation, and you should see the heart rate come back with effective ventilation. Are there cases where you need to do compressions? Absolutely, but that was just my mileage, and your mileage may vary. However, understand that if your brain is switching from adult mode to neonate mode, effective ventilation is the key component here. The last point here that we'll focus on in this presentation is teamwork, leadership, and communication are critical to successful resuscitation. We can be great at being individually skilled providers. However, if we're not communicating, if we don't know who's leading the teamwork, if we don't know what the next step is, if we're all doing our own things without communicating, we don't know what the next plan is. We don't know how to approach the rest of this. So teamwork, leadership, and communication are critical to successful resuscitation of the newborn. Even though you could have the most highly skilled people with the most degrees, the most years of experience, the most training, but if they don't communicate to each other, it's still going to be very poorly run resuscitation. So let's get started. The NRP program is a goal to resuscitate neonates. Neonates anything from birth to 30 days. The goal is to learn. What's the goal of NRP? It's to learn cognitive, to learn technical, and to learn teamwork skills to help you resuscitate and stabilize newborns. Notice it's not just about technical skills. This whole program is not just technical skills. That's a great goal to have. However, we need the cognitive part of it, and we also need the teamwork skill part of it. And so that's why you'll see with this program that we use a lot of scenarios to help build that teamwork component. And when you practice these scenarios, I need you to practice different roles. I need you to practice the roles of recorder. I need you to practice the roles of the medication person. I need you to practice the roles of team leader, right? I need you to practice the role of the respiratory therapist, and so on and so forth. I need you to practice those roles so you know what it's like in each of those roles, so that way you have skill built in those, as well as teamwork and leadership as something that's part of it. So the cognitive part, we're going to get into that as well. Most transitions to extrauterine life happen without intervention, and there's a reason why I brought these pictures up that you see on the screen. One of my favorite movies as a little kid, right? And then you see this scene here, and if you ever wonder, right, go back and watch this scene. You're going to see that, hey, most of those puppies were born and didn't need any intervention whatsoever. However, Lucky, that little puppy, right, needed a little bit of resuscitation, a little bit of help, which in this case was just warm, dry, stimulate, right? Warm, dry, stimulate. So little things like that make a big difference. So like I said, a lot of deliveries that you may go to, even if you're on the high-risk delivery team, they may not need any resuscitation whatsoever. We may just warm, dry, stimulate, put them back on mom, never even take them to the warmer, and then have a nice day, right? Happy birthday, right? So it's going to be one of those things where if you do need to use your skills, you're ready to go, but if not, it's a good day. 85% of term deliveries, the baby will begin to breathe within 30 seconds after birth. That's pretty quick, right? From the lungs being filled with a bunch of fluid and being connected to the umbilical cord, which the placenta is the lungs for the baby in utero, right? It's delivering oxygen, it's getting rid of all their metabolic waste. So when we're looking at this, that's a really quick transition. So there's a lot that can go on in this transition. And even with high-risk deliveries, C-section is actually still considered high-risk delivery because they don't get that vaginal squeeze. They don't get that thoracic pressure as they're coming out, and therefore there's less elimination of fetal lung fluid. So that can play a factor. So understand that this is a pretty amazing transition they're going under, and most of the time they won't need our intervention. Sometimes they may, but we'll get to that in a bit here. About 10% of babies will begin breathing as a response to drying and stimulation. So if that kid is still apneic, and most of the time, especially if we're doing a delayed cord clamping or something like that, which we'll talk about in a different PowerPoint, then we are going to be waiting a little bit. And so if they don't respond just to being pressured coming out, drying and stimulating is an easy way to just sort of help stimulate them that say, hey, you're on the outside. You're no longer relying on the placenta. You need to do this on your own. Happy birthday there. So we need to make sure that one of our first steps, and if you have that NRP book with you, is going to that algorithm and looking that warm dry stimulates one of that first part of it. And then sure enough, you see it in this movie, right? Good old 101 there. You see all he did was warm dry stimulate, and that was enough to begin that resuscitation of. All right. When we're looking at this, only 5% of term newborns receive positive pressure ventilation. So if you're asked to go to a term delivery, and that's one of the things that you're going to understand is what's the expected gestational age of this baby or babies if it's a multiples, hey, what is the gestational age? And if it's term, only 5% of term newborns will actually need PPV. That means that their lungs are developed. The last organ system to develop is the lungs. The first organ system that this kid needs when they come out is their lungs to help change their circulation, to help start closing their shunts. And so that's what makes that transition kind of a unique situation. But understand if it's a term delivery, only 5% of term newborns really need PPV. Most of the time, they might need some suctioning, if anything, but PPV, very rare in those patients. Only 2% of them will need to be intubated, so even more rare. Right, so this tells you that your NRP is more likely to be used in a preterm baby than a term baby if you're looking at this in that direction. 1 to 3 babies per 1,000 births will receive chest compressions or emergency medications. So that's pretty low, right? Very low statistics there. So chest compressions or emergency medications, very rare in the NRP program. Are we going to practice them and build that skill so that way you're ready to go when you see it? Absolutely. But in the meantime, understand it's a rare case. However, that does not mean you can go lax on your skill. Subsequently, the likelihood of requiring interventions is higher for babies with risk factors and those that are preterm. So if you have babies where there's a meconium stained fluid, right, where there could be a possible meconium aspiration, or a kid that has a known congenital defect going on, like a congenital heart defect, a kid that's preterm, so those babies are more likely to need positive pressure ventilation, intubation, emergency medications, and or chest compressions. So understand we need to know what are risk factors, and that's going to be one of our parts to this program, is identifying what risk factors we're going to be more likely to set things up with. And then finally here, the need for assistance cannot always be predicted. Be prepared to respond quickly and effectively at every birth. I cannot tell you how many births that the high-risk delivery team that I was a part of was asked to go to, and sure enough, everything seemed fine, and then all of a sudden something changed and we needed to do something. So you can't just sort of be sitting on heels being like, hey, this is a term birth, I guess I won't make sure I have all my equipment ready to go, I guess I won't check my FiO2, I guess I won't check my tank pressures on my warmer, right, for my gases, I guess I won't check my TPs to make sure it's at the right pressures, or my full inflation bag and make sure it's at the right CPAP. Right, so you can't be lax on those. Every time you go, prepare for the worst, expect the best, okay? That's one of the things that I always put in my brain. Prepare for the worst. If I have to resuscitate, I have everything prepared. But I expect the best. And so the best scenario, the baby doesn't even come over to me. No one knows that I was in the room. That's the best scenario, right? But if I'm prepared for the worst, that kid comes over, I don't want to be caught unprepared. That would be a very difficult emotional situation for a lot of people. Not being prepared and a kid's resuscitation being delayed or impeded because I just, didn't feel like I needed to do it at that point. So prepare for the worst, expect the best. So get everything ready to go as if you're going to use it. That doesn't mean break open the code card and all that, but that means make sure you got everything immediately available if needed, but expect the best. All right, so when we're looking at this, we need to learn how to evaluate the situation and a newborn. How do I evaluate the newborn? What should I be looking for? What is the situation? What's mom's risk factors? What's the plan for the umbilical cord? I don't know any of these, right? So we need to be able to look at that situation. We do need to be able to make decisions about what actions to take. If this is going on, if the baby is apneic, what is our plan? Are we going to do CPAP or are we going to do PPV? Well, if they're apneic, I'll tell you now, PPV, right? So we need to be able to make decisions about what actions we take and what we've been evaluating. We should practice these steps involved with resuscitation. So I'll tell you now, if you have the Neonatal Resuscitation book, go ahead and open it to the algorithm, and you're going to see that flow chart of the steps involved in resuscitation. And we're going to practice these and practice these and practice these. Eventually, they should become that second nature to you. And then practicing together produces results over time. Why practice together, Derek? Why can't I practice this at home? What's the importance of practicing it here? Is that teamwork and communication aspect is a big ordeal when you have people saying this and that, and you don't know who the team leader is, or maybe you're the team leader and you don't know what questions to ask, you don't know what assignments to give. You're not going to be able to practice that type of didactic format at home by yourself. That's just the case. So practicing together will produce results over time. The more and more you're involved with that care team, the better. I remember going to a delivery with one of my neonatal nurse practitioners, and we went to this delivery. It was a 28-weeker. It was a vaginal birth. We went there, and we had communicated well beforehand what our roles were. And it was like one was our right hand, the other one was our left hand. We got that baby intubated. We got her surfed, right? We gave her surfactant replacement therapy within minutes of her birth, and we were able to get her stabilized and over to the neonatal ICU after a little bit of time with mom and get her settled in there with lines and everything good to go. But that practice that we had together, that experience we had together led to that good communication, led to that smooth, stress-free flow. And you're like, there, that doesn't sound stress-free. The more you practice together, the more comfortable that you'll be with each other, knowing how to communicate effectively, knowing what we're looking for. That's going to really lead to better results over time. Expect a gradual improvement. Gradual is a key word here. Gradual improvement. I'm going to go ahead and underline it. In proficiency and speed of reactions, you're not going to be that fast to begin with, and that's okay. That's why we practice these in the lab. That's why we practice these scenarios before you go live with them. So a gradual improvement in proficiency and the speed of reactions is expected. Now, immediate improvement, that would be great, but we're not all there all the time. So gradual improvement, we should start to see that, right? So this is a chance for you, humble yourselves, look for opportunities to grow and develop that as we go through this. You need to develop that choreography, and right now you don't know the choreography. And so once you get that choreography down, gradually over time, you'll be able to do it faster and faster and more effectively. The best aspect of skillful assistance to a compromised baby is that your efforts are likely to be successful, right? So you really need that skillful assistance, right? Skillful assistance is the key component of that statement. That baby is compromised. They're not doing well. Their transition is going poorly if you're using this resuscitation. So the best aspect of helping that baby is making sure that you have this good teamwork and skills, right? that skillful assistance, that developing of the intubation, the developing of the warm dry stimulate, the developing of proper bagging, the developing of CPAP administration or TP's administration are going to be a key component. So make sure that you're working on those. Time spent learning and practicing is time very well spent when we're doing this. The more you get comfortable with this algorithm, going through the algorithm, thinking through what are my risk factors, asking my 4 questions at every delivery, going through the steps of the algorithm, CPAP versus PPV, if we have to do compressions, if we have to do medications, what are they? What's the dose? If I have to give volume expanders because they're cord separated, what's that volume that I'm going to give? And how do I know how much to give? So time spent learning and practicing is very well spent in NRP, and so we'll work on that. So what's the difference between adult resuscitation and newborn resuscitation? In adults, cardiac arrest and coronary artery disease really causes arrhythmias that prevent circulation. So the big focus here is on circulation, right? It's really on cardiovascular tone. Is that saying babies can't be born with poor cardiovascular issues? No. There are babies that are born with things like congenital heart defects that need to be taken care of, especially like an HLHS, hypoplastic left heart or something like that. But in general, what's the difference between neonate and adult resuscitation? Adult resuscitation focuses on cardiovascular, right? The arrhythmias that we're seeing, arrhythmia recognition. Neonate should only have about 3 different rhythms: sinus brady, sinus tach, and SVT. Other than that, we're looking at some very serious issues that can go on there. When an adult, we're looking at circulation to the brain will decrease. The adult will lose consciousness, and then they'll stop breathing. So notice that the breathing stops after the circulation. So which comes first? Circulation failure, right? So who do we need to fix? Well, we need to fix circulation, so that's going to be compressions. And ventilation stopped because we didn't have any perfusion. So in an adult, the PaCO2, the amount of carbon dioxide in their artery, is usually normal at the time of the arrest, and the lungs are filled with air. So that's traditionally. Now, if you want to get very deep into respiratory therapy, there are 2 types of failure, right? Type 1 and type 2. One's oxygenation, one's ventilation. So that gets a little bit deeper, but we're not going to go there. But currently, just assuming it's a cardiac failure only, then usually they were breathing fine. Their heart just decided to stop, right? And their level of oxygen, their level of CO2 are good to go when they arrest. And so the big component of successful resuscitation of an adult is chest compressions to maintain circulation until defibrillation, rapid and early defibrillation, and or medications to restore the heart's function. So in an adult, medications and compressions, defibrillation, those 3 things are a primary focus. I'll repeat that again. In an adult, compressions, circulation, defibrillation, medications are an important focus in adult resuscitation because usually it's the heart that stops first. But in a newborn, that's where we're moving over here. This is your compare and contrast part, right? In a newborn, most newborns have a healthy heart. Respiratory failure interferes with oxygen and CO2 exchange. So the big point here is ventilation. Ventilation is big, not necessarily as much perfusion unless we have a known heart defect. The lungs are the last organ to form and are filled with fluid in utero. So this is the last organ to form, so the more preterm they are, the less likely they are to have effective ventilation. And we'll talk about surfactant a little bit there too. The more preterm they are, especially 28 weeks and under, the less likely they are to have mature surfactant to make it easier for them to breathe. Imagine having a car engine that doesn't have any grease or oil in it. How well is that engine going to work without any lubrication? It can seize and cause trauma to itself. Well, and that's what we see with these preterm babies without surfactant. Mature surfactant is their lungs try to expand and collapse, expand and collapse, expand and collapse. And not only that, it's causing damage when they are, but now we're also having a hard time expanding the lungs because of something called surface tension. And surfactant, reduces surface tension. It makes it easier for the lungs to expand, easier for the pulmonary vessels to dilate, easier to get oxygen into the bloodstream, easier to get CO2 out of the bloodstream. So there's a lot that goes on between that development there. So the more preterm that baby is, the more likely they are to have a harder time with transition. The lungs are the last organ to form and are filled with fluid in utero. And the primary problem in these neonates with resuscitation is the lack of gas exchange. You don't even finish developing your alveoli. This is in the Walsh pediatrics book that you guys will be going through. The lungs alveolarization is not complete at birth. You're still developing the gas exchange parts of your lungs. You're still developing your respiratory zone up until about 7 or 8 years old, right? You're still developing that. So the primary problem in a neonate resuscitation is ventilation, the lack of gas exchange. So the focus of neonatal resuscitation is effective ventilation of the baby's lungs. You should write this down and put it on your badge, right? So if you forget in the future, a baby comes in, someone's born, and you're trying to resuscitate, is medications and compressions the primary focus traditionally? No. Your primary focus is got to be on effective ventilation of the baby's lungs. So what makes the babies different? Respiratory function is performed by the placenta in utero, and that's one of the reasons why some high-risk deliveries might be looking at late and or variable decelerations between the baby's heart rate and the contraction. So if we see a big disagreement between the baby's heart rate and the contraction, usually when mom contracts, when the uterus contracts, then we're going to see the baby's heart rate decrease a little bit, right? We're going to see a heart rate change. So what we're seeing here is a correlation. But if they're not correlated at all, it could be late or variable decels, there could be a problem with what's known as utero-placental insufficiency, right? That means the communication between the placenta is not very strong, and that baby could be under a lot of distress. So usually we're going to put mom on a lot of oxygen. We're going to try to reposition her, reposition the fundus, right? See if that helps. And if it doesn't change, this could have a poor transition. We could always do a scalp pH to see how bad the situation is. We can always look on ultrasound too to see how depressed the baby may be, right? If they're not responding, then that may be a sign that we might have to go to a more urgent or emergent C-section. So the function of the placenta is a key component to this intrauterine health. So if there's a partial abruption, which means the placenta is coming apart a little bit, that could be a decrease in oxygen delivery, nutrient delivery to the baby. It could lead to a lot of bleeding issues. It could lead to hypovolemia. So we need to make sure that that placenta health is a primary function. If there's an infection in the placenta, that could be a huge thing as well. A healthy placenta transfers the oxygen from the mother to the baby and carries CO2 away from the baby to the mom, which then the mom will eliminate naturally. So when we're looking at this, a healthy baby makes breathing movements in utero, and that's part of what's known as a biophysical profile, and we'll cover that in detail. And one of the components of that is fetal breathing motion. So they're not breathing gas, right? They're just moving fetal lung fluid in and out, and this is good. It helps develop the lung tissue. It helps expand the respiratory zone. It helps expand the lung tissue and grow, and it also makes sure that when we're looking at their strength of the respiratory muscles, it helps develop that as well. So really, it's a pretty important thing to see that fetal breathing motion. Even though they're not breathing gas yet in their lungs, they're using that to help move fluid in and out. They're using that to help develop their lungs as well. So when we see failure of the placenta, that means there's failure of the respiration. There's failure to exchange gas, which means this baby could demise, which means it could be an urgent or emergent delivery. So placental health is a very important aspect of neonatal resuscitation. So knowing that risk factor, knowing that mom's having vaginal bleeding, knowing that we're having issues with the contraction to heart rate correlating, then that could be a sign that the baby has inadequate oxygen, delivery of oxygen, and it could be a sign that they have inadequate removal of CO2. That baby could be born very acidotic and have trouble with that transition, right? That's not a good way to be born, especially with that organ system that's just developed. So monitoring shows low activity, heart rate variability, and decelerations if we have poor placental health. And so that's one of those things. Do you care about the placenta, the contraction to heart rate monitor? Yes, you do care, because that can tell us about the health of the placenta, which is the lungs in utero. And if it's poor correlation or poor health, then that could be a lead possibly to a poor transition. So make sure we get mom oxygen, as much oxygen as we possibly can, and make sure we reposition, make sure we deliver if needed as soon as possible. If this persists, the baby will show reflexive gasps followed by apnea and bradycardia. And you're going to see this if that happens in utero, where they go apneic and bradycardia. That could be a sign to go ahead and go with an urgent to emergent C-section delivery, and then you're delivering that baby. Are you going to expect them to breathe perfectly normal when this baby comes out with these situations? Absolutely not. So this baby, even after delivery, if we put them on PPV, might still have gasping and apnea periods and bradycardia periods until we're able to get the acidosis fixed. And so getting them turned around from that acidosis might be a key component. And this is like what I was saying earlier. We might do things like fetal scalp pH monitoring, right? Where we just take a sample from the scalp and run that pH and see if it's above 725 or below 725, right? So those are all things that we'll look at. All right. Early versus late phase. If delivered in the early phase of respiratory failure, so we determine that a baby is in the early phase of respiratory failure, and we deliver that baby urgently, right? We deliver them pretty quickly there. Tactile stimulation might initiate the spontaneous breathing recovery, hence the picture, right? So just that tactile stimulation, rubbing their back, right? We don't flick heels, we don't spank the kids, none of that. It's just mostly just rubbing that back. Usually that tactile stimulation might initiate spontaneous breathing and recovery. That's why I like this scene from that movie so much. So that's what you're looking at there, is just that warm, dry, stimulate. And of course, if you have that NRP algorithm in front of you, I encourage you to have it in front of you during these recordings. But that's what we're looking at, is just that warm, dry stimulation. Should do it if it's the early phase of respiratory failure. It's pretty much a wake-up call for that little baby. During the late phase, it's been a little while. This kid's been depressed for a while. Stimulation alone will not be sufficient, and they might require assisted ventilation. And here you see a picture of a T-piece resuscitator. This baby is very preterm. This is a low preterm bag of mask. And here you can see little pulse ox on the right upper extremity. They have the baby wrapped in plastic, which keeps the warmth in. So we'll talk about all of this stuff with our high-risk delivery information. They, of course, put a hat on this baby to keep as much heat in as much as possible. But this baby needed PPV, and so it's more likely either this baby is preterm and they don't have the surface area, so that risk factor, or if a baby that's term, let's say the cord separates in utero or the placenta has an abruption, then they're more likely to need that positive pressure ventilation if they were delivered in the late phase. So if they say this has been going on for a while when you show up to a delivery, you might expect and be prepared to go ahead and do positive pressure ventilation. If they're severely affected, they might require chest compressions and epinephrine. Have I had these cases? Absolutely. So you're doing PPV. It's effective PPV. You see chest rise, right? You have the right size mask. You're doing good technique, or you're using a T-piece resuscitator like you see here. In this picture, you might still have to need chest compressions and epinephrine. The epinephrine vasoconstricts. It helps with contraction of the heart as well. So that will help with perfusion and back pressuring blood to the brain with the epinephrine. And then the compressions obviously also helping with perfusion to the brain and the vital organs there. So in that late phase, expect to do PPV. If they're really severely effective, if they've been depressed for a while in utero, especially, then we might have to go ahead and expect to do compressions and medications. And the good news about high-risk deliveries is that umbilical stump is central access. So we can access the umbilical vein, the big floppy one in there, and there's pictures of this in your book later on in the chapter for your neonate resuscitation book. And then we can go ahead and start central infusion of epinephrine, central infusion of fluids if needed, or blood if needed. At delivery, you may not know if it's early or late phase of respiratory failure, so we just need to make sure that, hey, you're prepared for the worst, but expecting the best. So during and after birth. So during a birth, the fetal fluid is squeezed out with the vaginal delivery, and that vaginal squeeze removes 2/3 of the fetal lung fluid, and the rest is reabsorbed in the capillaries and the lymphatic tissue in the lungs. So we're going to see that reabsorption happen. But that means that if they go by a C-section, they're not going to get that squeeze, and they're more likely to develop what's called transient tachypnea of the neonate or newborn. So it's called TTN. So they're more likely to have that fluid just hanging out in there. And TTN is a diagnosis of exclusion. We have to rule out a pulmonary infection. We have to rule out a lot of stuff. But ultimately, that's because they take a lot longer to reabsorb that fluid because they didn't get that squeeze to remove that fluid. Lungs must take over respiratory function from the placenta, and they need to be filled with air to exchange gas. So that's why transition might be delayed in babies that have a C-section compared to babies that are born vaginally. So that's why it's important to know if it's a vaginal birth or a C-section. Traditionally, you will know that can affect the transition of that baby. Respiratory failure occurs. If respiratory failure occurs, the primary problem is the lack of gas exchange. It's very few and far in between that it's a problem because of the cardiac function, the cardiovascular function. Traditionally, it's going to be a respiratory gas exchange issue. So what's your intervention there? Either CPAP if they're breathing, or positive pressure ventilation if their breathing's not effective. So the focus on resuscitation, notice this is bold and underlined. The focus on resuscitation is on effective ventilation. Establishing effective ventilation of the baby's lungs during resuscitation is the single most important concept in NRP. So if you're having an issue, then the question is, what do we do with this baby? They're not transitioning well. If it's 5 years from now, 10 years from now, and you don't remember, just remember to help them breathe. Effective ventilation, right? So what is the single most important effective step in neonatal resuscitation? Right? Teamwork and identification of the risk and factors, but remember, we're trying to look at effective ventilation, but we do need to look at teamwork and identification of risk factors. Is the cord separated? Do we have a perfusion issue going into this? Are we going to have a poor transition? Is there a C-section? Is that a risk factor for the kid getting that squeeze? Experienced providers and effective communication are going to be a thing. Someone that is just there and they've never practiced these skills before, they've never practiced the teamwork component of this, are usually not going to be the most effective resuscitators. So effective communication and experience really will help identify not only the risk factors, but the coordination of the team as well. Placental health, term delivery, and early phase tactile stimulation really do play a role in making sure that we know what risk factors are there. Is the placental healthy? Is this a term baby? And then making sure we can deliver early phase tactile stimulation usually will help rejuvenate that baby. But effective ventilation of the baby's lungs is the single most important, right? So if you were to ask which one of these four, right? If I were to ask you a question down the road, which one of these four is the single most important effective step in neonatal resuscitation, you're going to go ahead and say 4. Yes, all of them are important. However, it's the most important is effective ventilation of the baby's lungs. Now, do we still need to coordinate teamwork? Do we still need to understand the risk factors that were going on? Yes, all those are there, but effective ventilation is the most important and effective step in neonatal resuscitation. All right, next question. How do we know if there's effective ventilation of the lungs? All right, which one of these would you say? An increase of the heart rate over 100, spontaneous chest and abdomen breathing movement. In other words, they start breathing on their own. Muscle tone and spontaneous movement of the baby starts to occur. And 4, the pulse pressure would increase on blood pressure monitoring. So which of these 4 would tell you that there is effective ventilation in your lungs? You're like, Derek, the most important step is effective ventilation. I know that. Well, now my subsequent question to you is, how do you know you're effectively ventilating the lungs? What are you going to monitor that's going to give you that feedback that says, hey, this is showing effective ventilation of the lungs? And the answer is 1, right? We're going to see an increase in their heart rates, right? So as long as we see that gradual increase in their heart rate, and hopefully we get them to a heart rate over 100, that's going to help them, because the tone is one of the last things to come back. Blood pressure monitoring isn't always done at delivery, right? Spontaneous and chest abdomen movement might not have anything to do with it. So an increase in the heart rate, a gradual increase in the heart rate, especially getting the heart rate over 100, shows that we're effectively ventilating the lungs. So you're at a delivery, things aren't going well. How do I know I'm effectively ventilating the lungs traditionally? If I got my heart rate moving on up. So putting that cardiac monitoring on, whether it's a 3-lead or someone auscultating as we're doing it, or palpating the umbilical stump, right? Whatever it is that we're doing, making sure that we're seeing that gradual improvement. If not, we need to take corrective ventilation steps, which is Mr. SOPA. All right, why do I need to understand transition? Well, transition from intrauterine to extrauterine life will help you understand the steps of neonatal resuscitation. Before birth, the lungs are just filled with fluid. We've already talked about that. Oxygen is supplied by mom's blood by diffusion across the placenta. So placental health is what we're looking for here for a good quality transition. If placental health is altered, then the transition might be poor. So you care about the health of the placenta when you go to these deliveries. Even if there's an infection, if there's something like that going on. Oxygenated fetal blood leaves the placenta through the umbilical vein. The pulmonary vessels are constricted in utero, so blood goes through the foramen ovale and the ductus arteriosus, which I have a picture on the next slide, mostly bypassing the lungs. In fact, the lungs get very little blood flow in utero. The blood flow they do get is to help develop the tissue itself, so to supply the tissue of the lungs with nutrition, not to give them gas exchange. So you're like, why is there any blood going to them altogether? Well, if you don't have any blood flow, you're dead, right? So the lungs need some blood flow in utero, but that blood flow they get very little, but that's all they need to develop that tissue, right? We need blood flow to the pulmonary tissues to develop. The rest of it will be bypassed through the foramen ovale, which is an opening between the right and the left atria, and then the ductus arteriosus, which is an opening or communication between the pulmonary artery and the aorta. So we're going to have most of that blood will bypass the lungs, right? So this means that in transition, these shunts, the foramen ovale and the ductus arteriosus, need to close to allow for blood flow to the lungs, to allow for oxygenation. So can we have issues if those don't close? Absolutely. In fact, there's adults right now that have a patent foramen ovale that wheeze when they're exercising because blood flow backs up into their pulmonary artery and backs up into their pulmonary capillaries and causes them to get a low-level pulmonary edema and wheeze, right? Ductus arteriosus, especially on preterms, can be open for weeks and weeks, and that can cause issues with pulmonary edema as well, because blood will back pressure from the systemic circulation into the pulmonary circulation and cause edema and cause oxygenation issues and cause surfactant deactivation or surfactant issues. So when we're looking at this, those shunts are important in utero to maintain life, And once that baby's born, as long as they don't have a shunt-dependent defect, then those will help that baby transition as they close. But this allows, those shunts allows oxygenated blood to flow to the brain and to the myocardium, right? So that way we're not spending it. So here's just a basic picture of the shunts, and here you see the ductus arteriosus opening in between the pulmonary artery. Let me switch it to yellow. Pulmonary artery and the aorta right there. And so this means that when we go to delivery as well, traditionally, if you see this, I'll try to get purple here. You see this that comes off the aortic arch? This goes over to the right arm. So when we do this, this also goes, that right common carotid, goes to the brain. So when we're trying to see how much oxygen is going to a baby's brain at delivery, this shunt, this ductus arteriosus, is still open. So I want to look at how much oxygen-rich blood is going to the baby's brain. Then I'm going to go ahead and put a pulse ox on that baby's right upper extremity. So the right wrist, the right hand, so on and so forth, because that'll tell me how much blood flow ultimately is going through that right common carotid to their brain. So how much oxygen supply is going to the brain is a big focus here, right, when we're looking at the pulse ox. But that's why we put that pulse ox on the right upper extremity at birth, because that's unshunted blood. Because right now we got bad blood mixing with good blood in that ductus arteriosus, which is why this is a different color, right? So we're seeing that there. You're going to have also the ductus venosus, which bypasses the liver, and your patent foramen valve, which is in between the atria. But the ductus arteriosus and the foramen valve are the big ones that we'll focus on for our purposes. All right, successful transition after birth. When the baby has deep breaths and they cry, that really helps aid in fluid absorption from the alveoli, because it's back pressuring, right? That back pressure, just like you're about ready to cough, right? You have that back pressure component to it. Well, that back pressure really helps push and cause intra-alveolar pressure to go up. If alveolar pressure goes up, then the pressure of the fluid is then forced hopefully into the lymphatic tissue, the type 3, so lymphatic tissue that surrounds the respiratory zone, as well as possibly into the capillaries. So the lymphatic tissue is usually going to be the big one, big component here besides the pulmonary circulation. So that crying, that deep breathing really helps aid in pulling that fluid into that vascularity and into that that lymph tissue that surrounds the respiratory zones. So air in the lungs, once air goes into the lungs with those deep breaths, it will dilate the pulmonary blood vessels. So we're going to have an increase in pulmonary blood flow. So as they take a deep breath, there's going to be a dilation of pulmonary capillaries. With low oxygen levels, your pulmonary capillaries vasoconstrict. And then when we give someone oxygen or when they breathe in air, then their pulmonary vasodilate. That's why patients that have pulmonary hypertension, where the blood vessels are constricted, one of the first things that we'll give those patients is long-term oxygen therapy. Because what does oxygen do? It pulmonary vasodilates. So as this baby is breathing air, they're going to have pulmonary vasodilation, which is going to allow for more pulmonary blood flow. So remember, most of the blood flow was bypassing. It was bypassing through the shunts, the PFO and the PDA. But now, as they are breathing air, then most of that blood flow can go through the lungs, and so they can pick up oxygen and exchange CO2 there. That increase in pulmonary capillary blood flow means the exchange of oxygen and CO2, and then that really helps them transition. So good, effective ventilation is a good transition for the patients. So here you see a picture on the left of constricted blood vessels before birth. Remember, most of the blood flow is going from the right side of the heart to the left side of the heart through the PFO and PDA. So very little of it's going through the lungs. It's vasoconstricted. We don't really need much blood flow there except for to develop the tissue. And then with this, if your pulmonary pressures are high, if you're vasoconstricted here, you're going to have higher pressure on the right side of your heart compared to the left side of your heart in utero. And so what happens when the cord is clamped and the baby starts breathing on their own, is these pulmonary vessels dilate after birth, right? They open up after birth as they start to breathe the oxygen, and the pressure on the right side of the heart decreases because there's less resistance to blood flowing into the lungs. Well, that means that the pressure decreases on the right side of the heart, and the pressure increases on the left side of the heart, which is what hopefully all of you that are listening to now have going on, is that you have a better blood pressure on the blood pressure is higher on your left side than your right side. So oxygenated blood returning from the baby's lungs helps to fill the baby's heart and ensure that the heart and the brain will receive adequate blood flow once the umbilical cord is clamped. So that umbilical cord clamping is a big ordeal. And in fact, we'll talk about delayed cord clamping in one of these presentations. But transitional circulation, as the baby breathes, the pulmonary blood vessels relax. The blood flows into the air-filled lungs. Blood returning to the left side of the heart from the lungs has the highest oxygen saturation. With this, the pressure changes from being higher on the right side of the heart to now higher on the left side of the heart. And that's what usually closes that patent foramen ovale. So think of that patent foramen ovale here. I'm going to draw a box heart picture. Right. All right, and here are your atria. And let's just say it's a little one-way valve there, right? So blood flows in there, and it's higher on the right side compared to the left. But as the pressure gets higher on the left side compared to the right side, that little one-way valve gets back pressured and closes, right? It's closing that little one-way valve. So therefore, the patent foramen ovale, once that pressure is higher on the left atria compared to the right atria, should close and help close that. Now, is it possible that it could take some time to close? Sure, but traditionally, it's a little one-way valve effect. Is it possible people can have these into adulthood? Absolutely. But traditionally, that should close with that pressure change. All right, in utero, the pressure is greater on the right side of the heart to allow for shunting, right? We want that, and that's what we see here in the picture, the fetal heart picture over here. We're seeing that shunting, and that's okay because we don't need to send it to the lungs. The placenta is doing all the oxygen delivery that we need it to do. Once that cord is clamped, it increases systemic blood pressure. So it's back pressuring, right? And so that's going to see pulmonary vasodilation. It allows for the pressure to decrease in the right side of the heart. And that's where you see this, the foramen ovale closes off. Because the pressure is higher on the right side, on the left atrium than the right atrium. So that's what we see here. Once that pressure changes, once that cord is clamped, we're going to have a change of pressure from being higher on the right side to now a change of pressure being higher on the left side. Closes that little one-way valve, closes that little thing, right? And so that helps close that PFO, and that transition should occur within minutes, but it may take a while, it may take days, depending on the situation. It does take 10 minutes for saturation to be greater than 90% on babies, and you'll see this even on our delivery cart here, and then most delivery carts will have a little chart from NRP on them as well to show you that. So relaxation of the pulmonary blood vessels occurs gradually. They're going to have pulmonary hypertension to begin with, but as they keep breathing more and more air, right, then that should help dilate and reduce the right side heart pressures, allow for more gas to flow through the lungs, allow for a better transition. So ventilation is a key component here. The more air they breathe, the more relaxation of the pulmonary vessels, the more their shunts will close, right? So we're seeing that effective ventilation helps these shunts close. Unless they have a shunt-dependent defect, we want this to happen. So effective ventilation helps these shunts close. So when a baby does it by themselves, great. But if they can't do it by themselves and their transition's poor, effective ventilation will help the physiology change to allow for better blood flow, better oxygenation of their tissues, right? So that's one of those things that we have to look at. So what about an interrupted transition? If an interrupted organs don't get enough oxygen, if we don't get them effective ventilation, if they're not breathing for some reason, let's say anesthesia has kicked in on the baby, right? Acid will accumulate in the tissues if they're not getting enough oxygen, if the tissues aren't. And then they're going to have a lot of vasoconstriction that not only occurs in the lungs, but also in the intestines, the kidneys, the muscles, the skin, right? So that's where you're going to see these babies look very poor in appearance, right? Look at the skin tone of this baby. Does that look like a good, healthy pink skin tone? So if it's prolonged, the heart failure begins and their perfusion decreases. And that's a sign that they might need compressions. That's that late severe stage where that poor perfusion will lead to organ damage, which includes the brain, which includes, all your other vital organs, your renal system, so on and so forth. So how do these babies present, right, that have abnormal transition? Well, if they're apnea or tachypnea, those are signs, wait, they're breathing faster than they should, or hey, this baby's barely breathing, if not breathing at all. So we might need to take those corrective steps. So bradycardia, tachycardia, low muscle tone, which is the picture there that I put onto the side there. You see that just poor muscle tone, that baby's just floppy. And then pallor or cyanosis, right? Here you see that pale bluish tone to that baby. And obviously low blood pressure or poor pulse, right? You have the inability for perfusion, or cap refill is very poor. What's going to be your ability to pick up pulse oximetry on this child? It's going to be very poor. So all these you got to take into a factor. If you see these assessments, right, that means you need to take intervention. And what's one of the most effective ways you can intervene on this kid? That's right, I heard you say effective ventilation. All right, so what's the structure of neonatal resuscitation? Rapid evaluation. Can they stay with mom or be moved to warmer for care? If the baby's crying and transitioning, they look pink, they're breathing, they're crying, they're flexing, they have good muscle tone, right? All these things are signs. They can probably stay with mom, right? Just give them a warm blanket and a hat, right? Make sure we wipe them off a little bit there, but right, if the kid is apneic, the kid has poor tone, if the kid has a lot of risk factors, we might have to go ahead and take them to a warmer for care. The airway, make sure we establish an open airway and support spontaneous breathing. One of the great things that most obstetricians do is suction the nose and the mouth. They suction the mouth, then the nose. There's an order difference there, but they suction them first before their whole body is delivered most of the time. So they'll suction the mouth first, then the nose. You always want to suction the mouth first, then the nose. Babies less than 6 months old are obligate nose breathers. And so that means if you were to suction the nose first and there's a bunch of goop in their mouth, they're going to breathe through their nose and all that goop's going to go into their lungs, right? That's in the oral pharynx. So we need to suction the oral pharynx first, then their nares. So that's why it makes a difference which one you do first. So always suction their mouth first, then their nose. Obstetricians are great at doing this, and you might get a baby and you might have to do the same thing. You might also have to suction their mouth first and then their nose. So establish an open airway to support spontaneous breathing. In fact, if the kid's not spontaneous breathing, is there a blockage? Is there stuff in their oral pharynx or nasal pharynx that's blocking them from breathing? So that's one of your assessments. Breathing. If the baby's apneic or bradycardic, we're going to do PPV, right? And this is the algorithm, which is the next slide. Positive pressure ventilation for apnea or bradycardia. CPAP is if they have labored breathing or low saturation, we can go ahead and do CPAP, but that's only with labored and slow breathing or low pulse ox. But if they're apneic or bradycardic, then we need to do PPV. So I will give you scenarios in practice of which one to do, CPAP or PPV, and so hopefully you'll be ready for that. Once again, that's great to practice, right? Circulation. We're going to assess circulation. Do they have bradycardia despite effective ventilation? That means ventilation with chest dry, so on and so forth. Then that really means we're going to have to go ahead and perform compressions, right? We're doing effective ventilation for 30 seconds and they're not responding. Then let's go ahead and go to compressions. Medications, bradycardia despite ventilation and compressions. So we're doing compressions, ventilation. We got effectiveness at both of those. then that's where we might need to go ahead and give them epinephrine. Well, how do we give them this? Well, we can do an umbilical venous line at delivery, and that's central access. Another option is intraosseous IO. In theory, there's still the endotracheal tube route, but however, that's not going to be as much systemic absorption uh, with uh, uh, with giving it through an endotracheal tube. So when we're looking at drugs as well, the last one that I put on here is volume expanders, especially if the cord separated in utero or the placental was abrupted. We're going to have a low volume baby. I can give that baby as much epinephrine as humanly possible, but if they don't have any vascular volume to circulate it anywhere, it's not going to be very effective at getting good perfusion to their brain. So volume expanders, usually normal saline, 10 mLs per kilo, can be helpful if they're hypovolemic. So here I know it's a small picture, but obviously the bigger one's going to be in your book. So this is the chart that you should be very comfortable with. Not only does it tell you the algorithm that you see there, but for babies that are breathing versus not breathing, how to assess them, but also looks at your oxygen saturation targets, right? Preductal, which would be the right upper extremity. It gives you your ventilation corrective steps, your Mr. SOPA. So mask adjustment, reposition the airway, suction the mouth and the nose, increase the positive pressure, or do an alternative airway like an LMA or an ET tube, right? So ventilation corrective steps. And then down here, it gives you endotracheal intubation things too. So it tells you the depth of insertion for the gestational week of the baby, or going by the weight of the baby and the ET tube size. So this is a very good chart to look at and become very familiar with. All right, teamwork and communication. This is a key component. Essential skill during resuscitation is teamwork and communication. It's not the most important part, but Joint Commission found poor teamwork and communication were the most common root of potentially preventable infant deaths in the delivery room. Could you imagine a kid not making it because you didn't work on teamwork and communication skills? You didn't practice those. You weren't able to communicate as a team any part of this, right? And that's what we want to avoid. That's the whole point of practicing this. This is the point of renewing your NRP and getting your NRP and keeping it current is you keep that communication skill, you keep that teamwork skill as part of your other skills that you need to deliver these kids. Once again, Joint Commission found poor teamwork and communication were the most common route for potentially preventable infant deaths in the delivery room. That's crazy, right? So you must perform multiple procedures without delay when we're resuscitating. If you're not communicating, if you're not knowing which person of the team that's going to do that, then it's going to delay care, and that could lead to a demise. Several caregivers are working in a very confined space. The baby's only so big, and you only have so much space to work on this kid. So there's a big potential for chaos. So each person's skills will not be used optimally without effective coordination. And that's a case there too. There's some people working in a skill that they're not developed in versus another person. That's part of the teamwork and leadership and communicating. Because if we don't communicate about that, if we're not working as a team to understand what roles each of us are going to have in our expectations, then this is going to go poorly, and that could lead to a death that wasn't something that could have happened if we would have had good teamwork communication skills. So the key behavioral skills you'll see over here in the picture on the right, and this is on page 10 or table 1-2 in the NRP book, shows these key behavioral skills. We need to know the environment, use all the available information we have, anticipate and plan and communicate with our team, right? We need to identify who's going to be the team leader, who's going to make the calls, communicate effectively. If we see something, we need to say something, right? Delegate the workload optimally, right? Are you going to have this person that's really good with airway breathing take over medication administration, right? Or putting in an umbilical line when that's not their primary thing. So delegate the teamwork optimally, allocate attention wisely, making sure we're focusing on the big things. Are we focusing on a line when we should be focusing on effective compressions and ventilations? Right? If those aren't optimized, then putting a line in won't make much of a difference at all, right? So allocate attention wisely, use your available resources wisely, call for additional help when needed. If we know this baby goes from being a low risk, where it's a 1% delivery, to high risk at delivery, we need to communicate that. Call a charge nurse over from the NICU. We need to do something like that. And then above all, try to maintain professional behavior and communication. That's a key component to making sure. There's a lot of emotions that rise up, especially when we're dealing with resuscitation of pediatrics and neonates, for sure. And maintaining a calm demeanor or maintaining a professional demeanor is going to be important to making sure that we take that emotional component that could block thinking and the skill of the team and the development of the resuscitation. We need to take that component and neutralize it as much as possible. And afterwards, we can deal with that emotional aspect. However, adding stress to that scenario is not going to help the team function any better. So maintain as much professional behavior as possible. Improving this skill, improving the teamwork and communication skill, requires deliberate practice under conditions that are realistic as possible. So you're going to see me when we do practice in the lab, I'm going to stress you. And that's on purpose. I want you to develop teamwork and communication. I want you to get that stress. I want you to understand what that feels like so you know how to deal with it, so you develop that skill. And how can I have you develop that skill just listening to a PowerPoint or just reading a book, right? Or practicing on a mannequin without anybody else, right? That's not going to help you, right? You need to practice this teamwork and communication skill under stress. Think about how these behavior skills can be used to improve your own team's performance. Every time we do this, I'm going to ask you what went well, what could have gone better, what could we optimize, right? So think about these skills. Did we anticipate and plan? Did we clarify a team leader? Did we communicate effectively? Did we delegate the workload appropriately? Did we allocate attention? Did we focus on something that wasn't important? Are we looking at something like a blood sugar when haven't even started effective ventilation yet, right? So are we using our available resources wisely? Do we have additional help if we need it? Do we need to are we not maintaining a professional behavior and getting in arguments that are not professional during the resuscitation? So these are the things that I want to see during these skills part of our lab. So think about them. Every team member has a responsibility to speak up and to inform the leader of observations that will improve resuscitation. Hey, if I see a baby and I see no chest rise when we're doing bagging and they're already trying to focus on compressions, I need to speak up and say, hey, I don't have chest rise with ventilations. Should we suction, right? Or I'm going to suction, I don't see chest rise. Okay, so we're doing our Mr. SOPA steps. I've repositioned my mask. I've suctioned, right? So that way I'm communicating to the team, right, what's going on. Because if I don't see chest rise, we can do compressions as much as we want to, but the key component of effective resuscitation, ventilation, effective ventilation of the lungs, right? So we need to make sure that we're speaking up when we see something that is important to the resuscitation. All right, some questions for you to be thinking about. In utero, the lungs are filled with, hopefully you said fluid, right? That's to help develop the lungs, expand the tissues, and all of that, but you're going to have fetal breathing motion that helps when we're trying to look at the lung expansion and the respiratory muscles. So that fetal fluid is very important. Fetal lung fluid is very important at developing pulmonary tissues. So those little babies with oligohydramnios, so low fetal lung fluid, can cause hypoplastic lungs ultimately. Number 2, how is oxygen supplied to the baby in utero? Hopefully you said the placenta, right? Mom is. So if we're having issues with utero-placental insufficiency or latent variable decelerations with their contraction to fetal heart rate, we're going to give mom lots of oxygen, right? So that way, whatever oxygen is getting to baby is going to be more optimized. So that should be helpful there. And then if we have any issues with the placenta where the baby's heart rate's not coming back up, or not, we might have to do more urgent or emergent delivery with them. Number 3, describe the blood flow through the lungs in utero. Hopefully you're thinking, okay, The blood flow through the lungs, very minimal, maybe a little bit to help develop the pulmonary tissues, but the rest of it, most of it's going to go through the patent foramen ovale and the ductus arteriosus and bypass the lungs because the level of blood being delivered is full of oxygen already from the placenta. So the oxygen exchange has already happened with their blood. So in utero, very little blood flow goes through the lungs just to help develop the tissues, but it doesn't need much more than that because it's not doing the work of breathing. The placenta is doing that. Number 4, breathing at birth has what effect on pulmonary capillaries? So my question is, does it vasodilate or vasoconstrict once they're breathing at birth? Does it cause pulmonary vasodilation or does it cause pulmonary vasoconstriction? Of course, you should have said pulmonary vasodilation, right? Once they're breathing air, it helps with pulmonary vasodilation. It reduces right-sided heart pressures, and that will allow for that patent foramen ovale to help close too, because now we have lower pressure on the right compared to the left. Lots of good things happen when that baby is breathing at birth. All right, true or false, number 5. Newborn resuscitation frequently needs chest compressions. Frequently, right? Frequently is a key word there. Of course, you should have said false. Not usually something that we do in our resuscitations, but it is possible, and we will practice it, of course. But most resuscitations usually don't require medications or compressions because their failures are traditionally pulmonary. And if it's a late phase, severe late phase resuscitation, could they require compressions and medications? Absolutely. But if it's an early phase resuscitation, most of the time it's just that dry stimulate. If it's that late phase, early on in the late phase, then we can do PPV. But after that, that's when compressions are needed. All right, number 6, true or false? Quiet and independent providers are effective at resuscitation. So people, just a bunch of people that are quiet, not talking, they're independent of each other, and they're really good at resuscitation. Well, that's false, right? We need teamwork and communication. If we don't know what the next plan is, the next line is, who's doing what, who's listening for the heart rate, who's putting the pulse ox on, who's getting the intraosseous, or who's getting the EKG stickers on, who's getting the umbilical IV umbilical line put in place so we can do medications or volume expanders as needed, who's going to intubate, who's going to help secure the airway once we're done, who's going to provide ventilations. If we don't have all that stuff down, we don't have that communication, we get the most skilled provider in the world with us, and it won't be helpful. So that teamwork and communication is essential to the success of this team. So hopefully you got a lot out of this presentation. Go back and listen to it again and try to keep it a little bit around an hour. So once again, go back through, read that chapter 1 of your neonatal resuscitation book. Hopefully this little thing is helpful to you. You can listen to it anytime while you're doing any type of task that you need to do. And I'll see you guys in the next video.